All right, thank you so much for having me. My name is Hannah Potts. I'm a nurse practitioner at the Cayuga Cancer Center. Many thanks to the Cancer Resource Center for having me here to speak. June is Survivorship Month for cancer survivors, and so I'm really excited to be able to highlight that and celebrate all of the survivors across the world. So here we are talking about seasons of survivorship specific to the cancer care continuum, but keep in mind that survivors of a lot of different things can occur. Survivors often are associated with trauma, and so I understand that there can be some buzzwords here that might be hard to hear. Please ask me questions if anything comes up with that. And just a reminder that we're talking specifically about the concepts of cancer survivorship. And so we're talking about from treatment, from diagnosis, treatment, and beyond. And these concepts, these phases of survivorship were really first presented in 1985 by Dr. Mullen. And Dr. Mullen, I apologize, I don't have his reference right here, is a physician who went through his own personal cancer diagnosis, treatment, and then wrote an article that really sparked the launch of survivorship, particularly with adult survivors. And survivorship is also really crucial in terms of how we historically think about survivorship, excuse me. It's really crucial to think about pediatric cancers. And that's because within the 80s and 90s, our ability to treat pediatric cancers really changed, meaning that we improved the outcomes for cancer patients that were young tenfold. And so young children with cancer were then living longer after their therapies, and we had to really consider what that long-term survival looked like. Now, no cancer experience is the same, no survivor's experience is the same. So in terms of when we talk about this, we're using examples, and we're thinking about it and how can we process individually those timelines, but also how can providers support patients? How can the community support cancer patients at different phases of their cancer care continuum? And how can caregivers support patients when they're going through these different phases? So broadly accepted within the professional realm, a survivor begins at diagnosis. So at that first onset of the consideration of a cancer diagnosis, you're a survivor. And the thing is that at the first consideration of a cancer diagnosis, through the staging workup and development of a plan of care, that can often take over 6 weeks. So 6 weeks, maybe on average, even sometimes longer than that. And that's a long time to be processing your, diagnosis, this potential diagnosis, what this might mean. The word cancer in and of itself is extremely scary. A lot of times we really have changed the cancer care continuum from a less scary realm when I think about what I do on a day-to-day basis. But when you talk about a cancer diagnosis, it's going to be scary no matter what. But that means that you're a survivor, you're going through something. And so the thing is, we also need to understand that cancer survivorship isn't linear. It's fluid, it's changing. No one experiences it in the same way as another patient. And so when we're talking about phases, we're just talking about how those different times can change how your experience is. So why I think that the term survivor, beginning at diagnosis, really works for cancer survivorship is because once you're dealing with a cancer diagnosis, you're going to be dealing with different aspects of what that means for you in various ways and throughout that experience, that cancer care continuum, as I like to call it. So it's broadly accepted by professionals that survivorship is not linear. It starts the moment of diagnosis, but much of the care surrounding cancer survivorship has really focused on that curative intent realm, right? So the patients who have earlier stage cancer and they're done with therapy. The historical relevance of survivorship is also based on pediatric cancer patients in terms of when we talk about cancer care plans and survivorship, long-term survivorship considerations. Because in the 80s and 90s, the ability to advance cancer care for pediatric cancer patients changed so drastically that we suddenly had this, new population of people living through and after cancer. And so we had to start thinking about these long-term side effects. We had to start thinking about what we call sequelae, or things that can happen because of an event, right? So you have a surgery, you may have a sequelae, which is because of scar tissue from that surgery, even though it was good outcomes, later issues that arise. So that really arose from the cancer pediatric, the kids cancer realm, right? So I know that a lot of the CRC clients are adults, and so some of that doesn't necessarily apply. But when we're talking about that cancer care continuum, the fact that survivorship when you're diagnosed is very different than survivorship after treatment, and very different than survivorship for those living with a chronic illness, cancer. Okay. So as we get through this, we're going to talk about some of those terms. If they don't make sense, please ask questions in the chat, and I'll kind of come back through to them if I missed something. And Bert, as our facilitator, please kind of flag me if I need to make sure that I highlight something a little bit differently. Okay. So acute phase. All right. We're going to talk about phases. We're going to talk about seasons. So if we think about our different seasons of survivorship, the acute phase is spring. There's a new diagnosis. There's shock. As Tolstoy once said, spring is the time of plans and projects. And when I'm talking with patients about a new cancer diagnosis and the need to understand that cancer diagnosis, I often will say, this is the time of information gathering, and information gathering takes time. So acute phase survivorship is often met with a lot of emotional turmoil, significant sense of urgency can exist. We need to, as professionals, be offering a lot of information about what that timeline might look like. So we have even the concept that from the initial suspicion of a cancer diagnosis to a final plan of care for the majority of patients is going to take over 6 weeks. 6 weeks maybe is on the low end of average, but if you think about that, that's a long time to be waiting to understand what that means. And especially because what we think of as cancer, when we immediately think about it, we think about scary and death. That's changing, that's evolving. So when I'm talking about cancer as a chronic illness, I'm also talking about the reality that most cancer diagnoses aren't emergencies. And that's a really hard shift to be making. Even as a cancer provider, as a cancer patient, you may think back to if you're through some of your cancer therapies, or if you're after the first year of your cancer therapy, you think back to that initial phase and you're like, what do you mean that was an emergency? That was life-threatening, right? So it's really, that acute phase is acute. There's a lot going on there. And the acute phase can really cause a significant amount of distress. And that's a whole nother conversation when we think about distress and how people handle that stress, and does it, are they able to activate their resources to minimize that? But what we're also thinking about when we're talking about these seasons, these different phases of survivorship, how can we handle them personally if we're living through that experience, but how can we also support our patients, our clients, and our loved ones as caregivers? So during those different phases, you're going to have these different needs also. Next phase, we have late acute or extended, and this is the summer phase, right? So in some ways, there's a little bit of sitting back. Things are starting to fold into a plan. There's a plan of care in place. Patients may be receiving different treatment modalities, chemotherapy, radiation therapy, hormone therapy. This is a lot about managing the ups and downs, right? So you've got a beautiful summer day, and then you've got a rainy summer day, and those are very different experiences, but it's still summer. Thinking about the change from acute to late acute, think about spring to summer. Here we are, we're about to come to the summer solstice. Just because the summer solstice is on Friday, it doesn't mean that on Sunday you're going to have a perfect summer day, right? So it's not linear. There's some fluidity. There may be some back and forth, even especially in those early components of how those things are changing. Patients are getting used to a treatment. They have to learn what that treatment does to them. Some patients will kind of get into a routine at this point, and they might start taking on new projects, right? Like they're going to have 6 months of therapy. They're going to start knitting. They start a project. They kind of find a space in there. Others might say, okay, I'm in this. I know what's happening now. Now I want to also be doing some rehabilitation stuff. So they might start an exercise program that we offer, or they ask about those questions. There's still a lot of emotional ups and downs that are going to be coming and going throughout any of these. And each person's experience is different. So keep in mind, as I'm saying some of these examples, I'm not trying to apply them to everybody's experience. I'm just trying to think about what happens during those timelines and why we can think of that season to help us understand maybe what those changes are. So during summer, you have a little bit of a period of latency, right? So a lot of changes happen when we think about the summer season, but also there's sort of it sort of like gets into its growing season, that latency. Transition, again, fall, extended. This is very different for different diagnoses and different stages of cancer. And this is where Dr. Mullen's initial study doesn't necessarily translate to the current era of cancer care, in that he talked about acute, extended, and long term, right? So he didn't really think about even this like middle phase of long acute or late acute. But when we talk about extended and transition, we're talking about, for example, early stage cancers that may have made a transition out of treatment into active surveillance. And so that summer phase, they might be starting to do some post-treatment recovery that extends into this extended fall phase where there's changes and they're kind of understanding what that new reality is, right? So it's post-treatment for many of those patients. There's a lot of change that can happen post-treatment. If we talk about breast cancer patients, they may have had a mastectomy. They may be moving towards trying to do some rehabilitation. If we're talking about more advanced cancers, the extended phase can happen during periods of remission, right? So a patient is treated and they go into a kind of a latency period. I don't love the term remission, so keep in mind I'm trying to use terms that apply in different ways, but it's sort of that moment of easing off of those acute treatments. But it also might be during treatment breaks. So patients that are on maintenance therapy, but they take a treatment break to step away from those therapies to see how they're feeling, to make decisions about further treatment. But then also extended maintenance therapy tends to fall into this fall transition because patients are constantly transitioning through what that chronic illness is to them. And that's where, for me, I think about this extended phase. It doesn't always apply in the same way. Coming back to that in a minute, okay? So the fluidity of survivorship, that non-linear aspect of it, for me, really speaks to the fact that with advanced cancers for patients with what we call metastatic disease or more chronic cancers, they may be moving back and forth between extended and summer a lot throughout their cancer experience. So patients may go into this period of good control with a diagnosis and management. They may have some progression, and so they kind of go back into that acute or late extended phase, but then they get control again and they go back into that extended. Transition is also a time when patients may be finding more about what their body can do. So for advanced cancers, they're kind of understanding, what does fatigue mean for me? How can I manage my fatigue? Which is a little bit different than for those earlier stage cancers that might be doing that in a different phase, okay? Again, none of these are linear, none of these are cut, black and white. Everybody's a little bit different. Next up, we have winter or long-term survivorship. So with pediatric cancer patients, this long-term survivorship was really about that extended multiple decades after their therapies of thinking about what they had to grow through. So pediatric cancer patients, in terms of fertility, was a big thing that kind of came up at 10 plus years later as we understood that. For women who are younger, diagnosed with breast cancer earlier, that long-term effect of a fertility could really be a conversation. The long-term survivorship and permanency is again a challenging conversation around the cancer care continuum of advanced cancers. And that's where I think of cancer as a chronic illness. So some patients will go into this long-term survivorship when they're in that extended maintenance phase, just because that's how they are able to settle into what this means for them. So if we think about metastatic cancers, we're thinking about treatments that control the disease and limit what the disease can do to the rest of the body. If we apply it to other cancer illness, chronic diseases, we can think about it like diabetes. So some patients will start with diabetes needing just a pill, metformin, that manages their diabetes for a while, but for whatever reason, it may not manage it forever, and they may end up needing insulin later down the road. During that entire time of that diabetic care, the provider is also doing assessments of their cardiac health, their kidney health, trying to minimize other complications that diabetes can cause, right? So those are not one-to-one examples, but my concept here is thinking about that chronic illness continuum. You're going to be thinking about that permanency of survivorship. And for some people, they may fall into that long-term. Others may have that extended transition and move back and forth between the summer and fall, depending on their experience. Thinking about patients who complete therapy, they may be adjusting to changes in their body. They might also be dealing with a lot of the kind of sudden understanding of the psychological effects of the therapy. They may also be sort of accepting the understanding of what that cancer experience and diagnosis means to their health history, right? So is that something that they identify with? Is that something they don't want to talk about? And as I mentioned, this could be a little bit more critical when we think about childhood cancers or younger. So it's going to be very different for a patient depending on the decade that they're in, honestly, because those decades, in terms of the next decades that follow, may be influenced by what types of long-term side effects we could be talking about, what chronic side effects we could be talking about, what risks and sequelae we could be talking about. The other thing is that I think that the long-term survivorship timeline in this winter is when we start thinking about how some patients can sort of fall into a traumatic phase of dealing with their trauma, or they kind of fall into a post-traumatic stress place. I do think that that's a little bit of a broad statement, so bear with me. But when I'm really trying to think about what are these different phases, for some people, that long-term survivorship, how they process, they can kind of fall into repetitive processing, and they need a lot more psychosocial support. Others don't need that same support, right? So just keep in mind that all of this is fluid, but thinking about what we can assess in terms of where they might be in their phase might be how we're going to offer treatments and how we're going to support those individuals during those treatments. So everyone has their own experience. As I mentioned, I think I said that a couple times, and I really wanted to highlight that because it shapes where they are within that continuum. And so each individual's experience is going to be different. These seasons are not perfect examples. The phases are by far not perfect. I think it's very different, as I mentioned, for our patients who are completing a set of therapies versus patients who are going to have maybe ongoing therapies. The historical concept of survivorship is different when we're talking about the current cancer care continuum, where patients may do 2 years of what we call adjuvant or post-surgical treatment for maintenance, right? So that's a very long, extended, acute kind of phase. And so then that long-term survivorship, when it hits and what they've already processed, may be very different. But I've talked about that fluidity, that it can change with the diagnosis in terms of if you have a recurrence. So somebody might be in a long-term survivor and go straight back to acute. Those transitions can be very traumatic for individuals and very complex in terms of understanding, wait, but I already moved past this, right? So as a caregiver, I'm often trying to talk about what that might mean in terms of survivorship, that you're still a survivor, right? It started way back at the original diagnosis. Just because we're talking about a change in what your cancer care needs doesn't change what that you are and what that experience is. Changes in regimen. So patients at various stages of cancer may have to change their regimen, whether there's an allergy, whether it's an intolerance. And sometimes those changes in regimens can be emotionally taxing. And so that can really send somebody to a different phase of the survivorship, in my mind. Sometimes it helps because it might be easier, it might be better tolerated, and it might move them through. And again, these examples are imperfect. They're just meant to have, open that conversation of what this looks like from, again, a lot of this is from also research and professional experience, but some of these qualitative studies that were done really did talk about what these themes were that happened over time for patients. So survivorship care is all about comprehensive care. And comprehensive care is focusing on addressing physical, emotional, spiritual, social, and practical needs. That comes to financial, that comes to housing, transportation, right? All of those things. So comprehensive care starts saying, what do we need to make this person whole, right? So you can think about like the hierarchy of needs, Maslow's hierarchy. I think I said that right. But you know, you really need to have food and water before you can think about your job. You know, it just that's a reality of how our day to day is. And within the cancer care continuum, we need to make sure people are moving through their treatments in that phase. But then let's start adding stuff in when we can, when they're ready for it, when we can offer it. And so our goal is always to be enhancing quality of life throughout the phases, to improve outcomes, and to support the individual through their own experience. And everyone's different in terms of what they want or need, right? So some people don't want social service support, right? So if we have a social worker who's available to offer extra resources, that still may not be something that that individual wants. But thinking about where these different things may fall within the cancer continuum and survivorship, I think about, you know, wellness programs and physical activity programs after the acute phase. During the acute phase, there's too much testing going on to start a physical therapy program for most patients. And while I want rehab, or what we call prehab, for every single surgical patient, the reality of that actually being applicable and utilized isn't always the case. So then we're also thinking about, when do we need to be doing outreach and education? What type of preventative and screening services do we need to be thinking about? So post cancer treatment, I still want to be thinking about screening for other cancers. I want to be screening for recurrence, what we call surveillance. For patients who have active cancer therapies, I might still be having conversations about screening for other cancers. And so these services are really meant to add richness and resources to what individuals need throughout their cancer journey experience. Um, One of those things is that is thinking about the difference between when do we need psychosocial services and when do we need those practical services. And sometimes you need them at the same time. Sometimes knowing that during transitions of an individual's diagnosis, so new diagnosis, acute phase survivorship, more psychosocial support may be needed just to help them process and manage the next steps of their therapy. Whereas those practical things might come into that second late acute phase where they're starting to contemplate, wait, oh my gosh, what do I need to think about in terms of finances for the second opinion I'm going to get, right? So there's different phases where some of those support services might be more needed versus others. At the cancer center where I work, our survivorship program is built on the concept that we have all these services that should always be available to patients. And the question that I'm often asking myself is, how do we make those patients know those services exist, right? And so sometimes it's about having the conversation, and sometimes it's just about having posters up, right? And sometimes it's having these types of conversations where we're talking about, well, survivorship care is also about comprehensive utilization of services to enhance one's individual experience, improve their quality of life. And so these educational and outreach sessions, I think, are really valuable to our community, and especially in the cancer, you know, survivorship realm. A patient may say, well, wait, I never thought about spiritual care as part of my cancer care continuum. And I would say, well, I can obviously understand that you might not have thought about that as that direct connection, but we have spiritual care. We can connect you with somebody who can have that conversation about what is the meaning of life. Some people don't want that, right? And then say, well, that's not part of what my needs are. Others might say, well, what do you mean a physical activity or wellness program? And I could say, well, I find that a lot of patients do better when they're more physically active. It doesn't matter if they're in treatment or active, you're out of treatment. So for some of our older patients, chair yoga can be really beneficial. And how can I refer to those services and enhance, again, their overall well-being? So what is a survivorship care plan? I jump a little bit to that because survivorship care plans are very much in vogue in terms of cancer care and considering what we do for our cancer patients. So within a cancer program, as a cancer provider, we really want to make sure that we're providing these patients with an overview and a roadmap for what their therapies are. One of the challenges with a survivorship care plan is that they're really built for the individuals with what we call curative intent therapies. So individuals with earlier stage cancers that are going to generally be thought of as going through a segment of therapy and then complete their therapy and have an active surveillance phase. So this classically was kind of known as those acute phase, long-term survivorship during that remission and beyond. We are able to modify them and use them for more advanced cancers. So patients that might be on chronic cancer therapies or maintenance therapies for the long term. And I'm talking, not those adjuvant 1-year therapies, but beyond that. It just gets a little more complex. And so sometimes easier things are easier to do. And so that's probably historically why they've been built off of that, curative intent framework. So a patient who presents this overview is going to say, here's what happened. This is what we found. So this is what workup we did. This is what your diagnosis is. And therefore we made this recommendation. This recommendation then followed through. You had this treatment. These are your doses you had. Here's complications that you had. Here's maybe what we had to do about those complications. And then a roadmap. Here's what your surveillance looks like moving forward. And so that's why it built off of that survivorship of the curative intent therapy and those classic, acute to long-term made sense for those care plans. We can develop them now to say, here's your diagnosis, here's the experiences and recommendations that we had with you in terms of your workup, your treatment plan, here's your treatment plan, here's issues that you have with that treatment plan, so we switched to this, and here's the plan moving forward. And then you can add to that and add to that. And that's one of the kind of newer realms of survivorship care plans, is how can we keep them as a living document? And I think that that's an area that just professionally, we have a lot of work to do. A roadmap is generally pretty static. And what we need to figure out is how can that overview being a kind of a living document and plan of care that grows and changes with the patient as things, arise and they need. So that's probably a larger conversation than today's presentation was meant to even bring up. But just, what I think about when I think about survivorship is how do we continue to evolve it to the evolving needs of our populations. Do we have any questions, or does anybody want me to talk a little bit more about something or bring back up any of those areas?
I had a quick question. I wanted to ask, so the way that you were talking about the seasons, it sounds like it is cyclical, but other resources that I've read have talked about how you kind of can bounce around through different stages of recovery. I think it's the grieving process where sometimes you can bounce around. It isn't necessarily a cycle.
Yeah. So you bring up a really good point, and I'm not sure when you jumped on, but one of those first things I talked about is that really classically survivorship is understood broadly to start at the diagnosis, right? At somebody's cancer diagnosis, that's when a survivor starts. But these seasons of survivorship are not linear. They're very fluid. And so people can move back and forth through them. And you referenced the grief process, and that's a whole nother layer of understanding how we process things that are traumatic, right? In a cancer diagnosis, it really is a traumatic experience, in my mind, can be understood and put within those frameworks. And that's a very different concept. The survivorship framework is meant to talk about kind of where during those different times of the treatment modalities or frames, are there needs that we can address? So within the grief process, there's going to be different responses, and certainly our desire to support at different ways. But the fluidity of the survivorship, seasons of survivorship and phases of survivorship concept, and in many ways theory, is that people will go back and forth depending on where they are within their cancer care continuum. So within the cancer care continuum, are they at diagnosis? Are they in treatment? Are they in surveillance? Are they in long-term survivorship? Are they on chronic management and maintenance therapies? And how do those different needs vary at those phases? Again, it's theoretical. I think the overlap with grief is really valid, but I think it doesn't fully identify what our goal of the concepts of phases of survivorship is to identify what is going on in that phase and what those needs might be. Because the acute phase, that early phase diagnosis, people need information. But when they're in the long-term survivorship, they might need more support than information. Do not get me wrong, I think education and reinforcing the needs of each individual is critical throughout your continuum. That's not my point. It's just that those needs might vary depending on where they are. Is that does that help clarify some of that concept, or does it muddy it more?
That was great. Thanks.
Amelia, you answered. Oh, you asked if I could put up that roadmap question. Yeah, so the care plan.
Thank you.
And I think of a care plan as two concepts: that overview and that roadmap, in terms of talking about what our plan is moving forward. So within nursing and nursing theory, there's this concept of creating a plan of care specifically around active and potential health issues, right? So with a care plan, we really start thinking about how do we monitor that known diagnosis that happened and we treated? How do we monitor the potential for these complications? What types of long-term side effects could this patient run into? And what are sequelae that they need to be aware of that would need to be notified of? We would need to be notified of. This also offers our collaborative physicians and other providers that same concept of here's what we'll be doing, right? And sometimes can delineate where those who's responsible for what. So if I think about prostate cancer patients who require hormone therapy, sometimes they'll do a year of hormone therapy. I would want them to get bone density screening sooner than the majority of men would or ever need to get. And that's because of the hormone impact on our bone density. Same thing with women with breast cancer. We might be doing more frequent bone density screening, but men who never got hormone therapy may not ever actually even get bone density screening based on primary prevention guidelines. So we also have guidelines to lead us through some of what this survivorship care plan looks like. We follow, again, I'm speaking more to my own practice, but also across the cancer care, professionals follow a variety of guidelines, the majority being NCCN, ASCO, and then the European guidelines. And then for survivorship, we're collaborating with a variety of institutions. So the American Cancer Society is a really strong site for survivorship. They have a lot of links and they have a lot of resources for patients and caregivers. They also focus on more specific information for individual cancer needs. So the difference between perhaps a colorectal cancer patient who might have more GI issues post-surgery than a breast cancer patient who might have more mobility issues after a mastectomy, right? Very different needs depending on diagnosis and treatment. And so the American Cancer Society, or the ACS, does an excellent job of offering a bit more in-depth information for some of those individuals. The Livestrong program, even livestrong.org, is a great resource for survivors. It's very much built on wellness and improving individual health, no matter where they are in the cancer care continuum. The local YMCA of Ithaca in Tompkins County has collaborated with the Livestrong and brought back an excellent exercise program that I'm really encouraging many of my patients to investigate and look at. These are individualized exercise programs that are focused on what each person's need are based off of an assessment, and individualized based off of what their treatments may be limiting them to. And then, of course, I can't help but plug our very own CRC and our peer support groups. And so for survivors at all different phases throughout their cancer care continuum, support groups can be really valuable in terms of having conversations with people who have gone through the same thing or might be going through the same thing, having conversations about what was helpful for individuals. In many ways, talk therapy can just be really valuable. And also knowing that you're not the only one that experienced something, I think, is really critical when we talk about these very life-changing events.
Absolutely. It's amazing how many people say, oh, other people are going through this. Other people have these same thoughts. Yeah, for sure. I have a question for you. You mentioned surgery prehab.
Yeah. So this is a concept that I wish we had a little bit more access to. It tends to be something that is built within studies and protocols at tertiary centers where there's just a lot more resources. And I have to admit that when you start talking about smaller community cancer centers and rural cancer care, you only have so many resources to so many individuals that can offer physical therapy. So there's limitations. But rehab is all about after something happens and recovery. So I think of rehabilitation, recovery. Rehabilitation is prepping somebody to limit the potential complications of therapies and interventions and improve outcomes afterwards, so sooner than later. So we are working on, for example, collaborating with a physician out of the city who has developed a colorectal surgery prehab program to minimize the risk of complications during surgery, decreasing infection rates, and improving outcomes in terms of understanding about ostomies before you get an ostomy. So our program has a very similar little, there's like these, what do I want to call them? They're like it's like an order set, right? So for a patient, I would make sure that they get certain types of physical therapy for certain diagnoses before they go to surgery. Most orthopedic surgeries, when you think about somebody who needs a new knee, they've usually done some physical therapy before they go to surgery, and some people would call that prehab, even though in some ways it's physical therapy that failed before needing surgery. Within the cancer therapy realm, it's this concept of let's get patients as like tuned up as possible in the best shape possible before we put them through a major surgery, and then also get them to recover quicker afterwards. So that's the concept of prehab, excuse me.
Great, yeah, thank you. Like with the prostate, like a prostatectomy, like it's, a lot of the guys that get that will do pelvic floor exercise prior to surgery. Yeah.
Yeah. And that's a great example. That's such a great example. So like pelvic floor PT before any type of pelvic surgery, whether it's male or female,
Any type,
super
right?
beneficial. Exactly. Right. You're all about strengthening that same, and even abdominal surgery, if your core can be stronger, we know that outcomes tend to be better for individuals that are healthier and more active. And so patients that are obese have higher risk of complications. That's a reality. If we can even just improve their outcomes a little bit before. The other thing is like prehab's about optimizing outcomes as much as possible. So trying to minimize somebody's cardiovascular risk or minimizing their diabetic risk before they go to surgery, right? So sometimes we're really trying to optimize their entire health picture before surgery, and that kind of falls into that prehab concept.
Yeah.
Good question.
Anyone else? Any other questions?
I have a comment that goes along with what you were just saying, Hannah, about an individual that I know that's in Florida. He happens to be one of my martial arts instructors, and he was having a posterior hip replacement. And he really, his son is a physical therapist, and obviously he is an educator and was in phys ed his entire life. So he really did a lot of prep and prehab. And, he sent me a video a couple of hours after that posterior approach hip replacement, and he was ambulating. And within 5 days, he was teaching martial arts again. So I think that just shows you that it's possible to really prepare somebody physically and emotionally and spiritually for something if they understand it better, and you have the resources and the motivation to optimize their outcome.
Yeah, and I think you bring up that concept. There is the motivation, there's the time. The goal of optimizing can always exist, and we can always have those conversations and collaborating across these different resources that we have, right? Just as community resources can offer, these wellness programs, but having that conversation about saying, we can improve your outcomes now by doing this. And we can also then say, okay, so think about many women with breast cancer, for example, are getting therapies before they go to surgery. We call it neoadjuvant. So we're trying to shrink the tumor to improve outcomes. So within that same realm, can we also be thinking about what else can we optimize for those women before they go into major surgery? Whether it's a lumpectomy or a mastectomy, it's still a large surgery. So are we getting them to physical therapy sooner? Are we making sure we optimize their insulin? And sometimes I think that it's true across, any of the healthcare continuum. Sometimes we do it really well and sometimes we don't. But the more we can talk about it and the more we can identify, how do we have those sets that are built along? And that's where that survivorship, care plan and thinking about survivorship early on, can we try and minimize those long-term toxicities, improve, even psychosocial and emotional outcomes? We've at least done a little bit better job by those people. They deserve the best we can try.
I'm thrilled that you all are doing that. That's so great. I don't recall anybody recommending any type of prehab or even core exercise, before my abdominal surgeries. And that is what it is. It was many years ago, but it's great to hear that that's like a forefront of the conversation. So great.
And I know that in some of our support group meetings, we've talked about promoting support groups to people. And, I understand that, during COVID, it was really hard and people were very reluctant. I'm a little, I guess I'm a little concerned. I feel like that's a wonderful opportunity that we have through CRC for support groups, but I just don't feel like it's being emphasized enough by like the care providers, or just the word isn't getting out. To me, it's been invaluable for me, and
I think
cannot state how helpful it's been.
I think you bring up just like the most important part about it too. Are we talking about these things? Do we have them out and about, right? Like, do we have pamphlets or, and sometimes what is important to a caregiver is that I don't just hand you a piece of paper, right? That to me, I'm not necessarily going to, if I hand you a list of support groups, I don't know if that's going to do anything. But if I can say to you here, I know these support groups have been really valuable to people who are processing their diagnosis and going through different phases of what that, care continuum looks like, whether it's at early phases or later. Maybe you don't need it right now, but I want you to know it exists, right? Even that little soft handoff can be so valuable. I think that Bert, we are so lucky to have coming through our cancer center and talking with patients and offering those things. And it's, I would take any feedback you want, Amelia, in terms of how can we get the word out
I
to those
so
people?
agree, Hannah, with the fact that like, no matter how many pamphlets you're handed or piece of paper you're handed, especially in the early phase, you're just overwhelmed. You cannot take anything in. Your brain is frozen. There's just nothing that can get through. And so I feel like it's important to maybe not just mention it once, but I think it needs to be reiterated, because you may have felt overwhelmed, but then now you're ready for maybe to talk to people about it, Thanks, Laura.
Thank you all. Is there anything else I can do to kind of add to some of the conversation, Bert, or just know I'm always a resource. I'm always happy to talk about survivorship. I think these concepts are not, black and white, and they're not meant to label anybody in one space. And so I look forward to ongoing conversations as we can have them.
Is there a pamphlet that they hand out regularly, Hannah, that talks about support groups and the Cancer Resource Center?
Yes, I'm trying to, there you go. Yeah, so for the Cancer Resource Center, there is a pamphlet it's a trifold that we have available in all of our waiting rooms. And also we provide it to every single patient that receives a chemotherapy teaching session. But as you mentioned, that's often during that acute phase where it can be very challenging to have those conversations about, well, here, think about this. And then the warm handoff, so I'm apt to always say, guys, there's this pamphlet in here about the Cancer Resource Center. They're an invaluable resource to you and they're free. It's your resource, right? Can I guarantee everybody's doing that soft handoff? I can't. But I do think that Bert does an excellent job of trying to put out that information. And I will actually think on, how can we offer more like reminders? We're working on a card rack. Did I say that right? A rack card? I don't know. Card rack. Rack card that we specifically are giving to patients at the end of their therapy, that reminds them that at the end of therapy, things can be complex and just emotionally unstable again. And how can we support you? Here's a link to the Cancer Resource Center. So we're really I'm impatiently waiting for them to allow us to implement. But we're also getting feedback from community members and patients in terms of how that wording looks, because it is such a kind of critical time in people's lives. And I think that, you bring up the value of the fact that like we probably never mention enough of these things, right? So I can talk here and present all of these resources that exist in terms of the psychosocial, spiritual, practical, and I can talk about the services we have. But how do we actually get those to individuals is much more complex and probably much more imperfect than it often is in a presentation.
And as the two of you are speaking about this, it's reminding me that it's quite common for a person to join a group because someone recommended it. I mean, sometimes we have the person who's just like, where are the groups? I want to be on them. They get on them. But, a friend said to me after my treatment was over, we have a colorectal cancer group. She invited me a couple of times. So finally I went and I got in there. I was like, oh my gosh, I didn't even know I needed this huge breath of fresh air. And when people say, they're going through treatment, no, you should come to this group. I'm really enjoying it. Then it's and we'll have to have some conversation about that and about how to be a catalyst for that. But
But listen to what you said. You had to be invited at least a couple times. So I think part of it is any of us are still in that overwhelmed phase, and we've got a gazillion appointments. And
I have an idea that we get Amelia to do a little snippet about how important support groups have been for her, and then we show it on our waiting room TV intermittently.
What a great idea.
I'm willing to do a little blurb about how, because
the CRC, you'd be a great person.
Ever since I was diagnosed in 2018, it has been such a great influence for me in my recovery. And ironically, Hannah, I don't even live in the area anymore. I'm like, I come there once a week for my martial arts training, but I live 2 hours away, but I still attend faithfully the support groups because they're that important to how I process things, even at this stage. I happen to be one of those people that was affected with bone density issues, and I'm still dealing with that now. So I feel like it's really important for me to keep my finger on the pulse and to encourage the people that are in the beginnings of their journey. They need to be able to see somebody that's like, didn't roll over and die. They're still here and doing stuff.
And I think one of the things too is that reality is within survivorship that we cannot negate the risk of complications, right? We can minimize those risks, and we can be clear and honest with you about those risks, and we can try and manage those risks. But you just called out something that's so critical in terms of saying that, look, I'm one of those people, I've gone through this and I'm still managing even some of those sequelae with gusto and vigor. Being able to see that is such a critical thing, especially when patients are going through that transition in that long acute phase. I really think about a lot of those people that sometimes can hit that plateau of emotional, I don't know if I can do this, right? And then you start thinking about, well, what other things do I have down the road to be thinking about? Are you kidding me? 5 years, right? It becomes a whole nother layer, and support groups can really offer that genuine touch point of, you can do this. It is possible.
We had a member the other day that was talking about feeling depressed and anxious, and we're like, wow, that's so normal, and it can hit you anytime. But if you don't hear that, you think, oh, there must be something wrong with me. I got through everything. I shouldn't be depressed now, but it can hit at any time. And here's another one that I'll tell you is lymphedema, that, it can come 2 years down the road. And if you haven't heard about it and nobody's ever talked about it, you might not even realize what's going on.
Right. And that's where that roadmap is, to me personally, can be really critical and really valuable, is that we have a nurse who's actually trying to talk through those layers with those individuals. But at the same time, that might be actually an acute phase of survivorship, if you think about it, right? They're going into this long-term phase, and all of a sudden they have this acute amount of information that needs to get digested. So how do we repeat it? Are we having those conversations? And, my dream of having a survivorship clinic where individuals could come and see a practitioner for 40 minutes and do that comprehensive review of what we need to be thinking about for those individuals. That's that recurring touch points. How do we, we're not just doing surveillance at those visits, we're talking about what do we need to be monitoring.
Yeah, that's a great starting point. What do we need to be monitoring? And we've talked about this in groups before. You don't even know what questions to ask, and you're not sure where that roadmap is taking you, or what sequelae will come up that you couldn't have even planned for. Like we said, it just comes out of the blue. You're just, whether it's a emotional thing or a physical, like lymphedema or whatever. You just don't know what's going to come down the road.
Yeah. You both have used a word that I don't know. I think it's sequela.
Sequelae. Yeah.
What does that mean?
So it's think of it like I actually meant to define that. I'm so sorry. I moved right past it. I knew it would be one of those ones. So a sequela is like a complication associated with, so I made the reference to the fact that like somebody could have a surgery and they could have a very good outcome, and then they could have issues later because of scar tissue or what we call adhesions, and they could have a small bowel obstruction. That's called a sequelae or a sequela.
A result or an effect.
And it's because of, and oftentimes it's thought of as a complication associated with a prior thing, but it's not a direct complication, it's an indirect complication that's often later. So like post-surgical complication of what we call an ileus related to anesthesia. Somebody gets anesthesia and has a major surgery. When they come out of that, they stop moving their bowels and they don't poop. That's a post-operative ileus. That's a complication of anesthesia and surgery. But 5 years later, they present with a small bowel obstruction that's linked to scar tissue or what we call adhesions. That's a sequela. Does that make sense?
Yeah, no, it's perfect. And you referenced what happened to me. It was 9 years after my second abdominal surgery. I had my first bowel blockage. I ended up having 5 of them.
Right.
And then
I didn't even mean to use your example. Wasn't even thinking, but that's a sequela of the treatments that you've had.
Yeah,
and not necessarily a toxicity, right? But it's a because of, and it's often within healthcare using the term of a negative. A sequela is rarely a positive outcome.
Okay, yeah. And then I ended up, a friend recommended I go and get abdominal massage. And she softened up she sent me home with exercises as well, and softened up my abdomen like to the point that she was shocked. And there's just so much out there as far as the post-treatment treatment.
Yeah, I don't even really know much about that, Bert, so I'll have to ask you that about another time.
Yeah, love to tell you about it. Absolutely.
Thank you for sharing your expertise, Hannah. I continue to hear wonderful, awesome things about you, even though I'm not in the area anymore. But I still have Dr. Bale as my oncologist. So, and I'm got my finger on the pulse there at CRC. Yeah. So, if I can help in any way to encourage people, I will certainly do that and consider it an honor.
Awesome. Thank you so much for having me. And Amelia, it was so good to see you. You look fantastic. And I'm happy to hear you're keeping the finger on the pulse. And I also appreciate your feedback and thinking about how can we continually, softly hand off those things that really can be beneficial.
Right. Yep. Thank you so much.